So when there is a drive towards designing sophisticated CARs to overcome resistance mechanisms, to really, with an ultimate goal to make them more durable, these come along with their prolonged side effects. For instance, B-cell aplasia is a clinical surrogate for CAR-T persistence and secondarily patient outcomes. Now, with more sophisticated CARs, bispecific CARs, allogeneic off-the-shelf universal CARs, targeting novel antigens, invariably the push is to make them more durable. So the net outcome in the future could be that the patient may not have their disease relapsing as early as they relapse now, but they eventually develop a number of infections, distinctive infections with intracellular pathogens, viral and fungal infections. And the long-term outcome of CAR-T recipients at the end of the day may not change even after achieving durability. So I think this is a great question. The risk of infections with CAR-T really depends upon several CAR-T factors, and we could divide them broadly into those that are indigenous to CAR-T constructs versus those that are due to interventions performed in the peri-CAR-T period, such as lymphodepletion chemotherapy regimen, the type of agents used, the intensity of regimen, the interval between cell collection and infusion, bridging therapy, CAR-T cell dose, signaling and costimulatory domain, target antigen, CD19 versus BCMA versus a novel antigen, etc. Additionally, cytokine release syndrome, neurotoxicity, and peri-CAR-T intervention confer risk of distinctive infections in the early period. And then there are delayed toxicities. Some are better studied, some not. Lymphopenia, prolonged cytopenia, B-cell aplasia, hypogammaglobulinemia. So these go hand in hand with durability of a CAR. I think as we move forward, particularly with this, ongoing pandemic and, development of newer and newer variants of concern, these are some of the factors that ought to be kept in mind.